Each year, Microsoft Research hosts hundreds of influential speakers from around the world, including leading scientists, renowned experts in technology, book authors, and leading academics, and makes videos of these lectures freely available.
I knew him most recently as the president and CEO of the American Medical Informatics Association, AMIA. He's now the immediate past president. And he's past chairman of the Institute of Medicine's Board on Healthcare Services, the National Committee on Vital and Health Statistics, and the Board of Regents of the National Library of Medicine. He's been involved in many studies and reports, some of which have done some foundational work in evaluating and understanding the role of electronic medical records. The topics that he's been engaged in and has a deep experience in over the years are topics at the forefront of the minds of our policy makers these days, as well as researchers in academic healthcare. Today he'll be talking about personal health information among competing public goods. Can American public policy find a better balance between individual freedom, health, privacy, and research? It's a great title, great set of topics. Don.
Thank you, Eric, and a kind introduction. And it's really a pleasure and I'd say an honor to be here. I'm sorry I haven't been here sooner because I've had a terrific conversations with a lot of people, obviously related to Microsoft over the years. Eric and I were actually panelists together on a Diane Rehm show a few months ago with Jonathan Weiner talking about personal health records. And of course, Kristen Toll has been a colleague, is related to AMIA, so it's not like I haven't had some interfaces. I sent Eric some actually set of topics that I'd be happy to talk about. But I thought that this one might, in fact, in light of, I think, really the importance that Microsoft plays globally as well as nationally, and also at the policy level, might be really a good topic. So I hope that it won't seem a little too arcane. It's kind of a 30,000, 20,000 feet talk. On the other hand, believe me, if you've been into relating to privacy policy, it's a contact sport, much like implementing computer-based order entry or any other kind of informatics tour de force. So at any rate, I will start by saying a few words about AMIA. I don't know how many of you are familiar with AMIA, the American Medical Informatics Association, but I want to talk a little bit about them. We've been involved, AMIA, in this issue of public policy and also national health information infrastructure kinds of discussions for at least 13, 15 years in Washington, and actually are frequently called upon by staffers because we're seen really as sort of a neutral player. AMIA is 4,000 informaticians from 53 countries, so it's pretty global as well. I will talk about the current state of privacy policy and also attitudes relating to it. It's obviously all these things could be an entire semester course, so I'm going to be truncating this a lot. I do want to talk just very briefly about the history of some of these thinkings, this thought, because actually things are changing. We often think that things don't change, but things do change. And then I want to talk about the current status of where we are. And ERA, the law just passed, actually has some interesting issues that are still going to be being sorted out over the next number of months and years. And then what I really want to do is hopefully make this somewhat controversial and stimulating to talk about how might we nudge essentially a better balance among these competing social goods. Because I think right at the present, in our country in particular, we really do not have, in my view, a healthy balance. And I think the fact of the matter is that, to my way of thinking, is not ideal. And maybe if we can talk enough about this, we might be able to shift the drift. So AMIA is an authority regarding the sound application of health-oriented information and communication technology. I enjoyed talking to Bill Kraus today about both of us are as interested in the CT side of this as the IT side of it. I think that's where a lot of the future needs to go. And then related issues. But we also are leaders in informatics education and policy and research. We have a lot meetings. Our journal is the most cited. JAMIA is the most cited journal in the field. And I'd urge you to look at the website at your convenience. We also have an American College of Medical Informatics of people who are thought leaders who have been elected as an honorary kind of group to that. What is it? This is my own definition. It's still sort of an emerging indoor sport. It's a scientific field that draws upon really information sciences and related technology to enhance the use. It's related to action. How do you use these things to do what you're trying to accomplish? So it's not so much on the IT or the CT as the T, but it's more like the verbs. How do you make the nouns work so you get complete sentences and get where you're trying to go? And whether it's healthcare or research, education management, or policy, we see it as a very key issue going forward. We like to think that we're amiable informaticians. We describe ourselves as not AMIA, but AMIA. We AMIA to please. So I think the idea is we're really interested in transforming health as well as healthcare from both personal healthcare and consumer dimensions of health records and so forth, up to and including public health, and down to the molecular level in translational bioinformatics. And then the other thing that I think we've done over the last 5 years is try to make the transition of informatics from what I would call a serious advocation or a serious club sport to a formally recognized profession. And I think we've pretty much accomplished that. We are also very globally interested, and we're the happy benefactors of a planning grant from the Bill and Melinda Gates Foundation to try to set up with international colleagues a global strategy to try to improve health outcomes and health status internationally, also through using informatics and also, again, particularly on the human capacity side, training, education, and better things. So I won't go through this alphabet soup of organizations that we relate to, but happily, I think excellent progress is being made. To start moving to the topic we're talking about, Richard Norton Smith, who's a well-known historian, has said, if presidents are governed by any law besides the Constitution, it's the law of unintended consequences. The point is that I've had a lot of work in health privacy over the years. I won't go through all this, except it's like 20-some years of a fair amount of engagement at the policy level on a number of these things. And the fact of the matter is, there's this quote, I don't know the source of it, maybe some of you do and you can enlighten me, but it's the two things you don't want to watch being made are laws and sausages. Yes, sir?
I believe it's from Bismarck Schoenhausen.
Okay, that's great.
The people who respect the law.
Because it's a great quote, and I think actually at least...
People who respect the laws and eat sausages should not watch while either are being made.
Right, yeah. No, I mean, it's one of those things that would make you probably most skeptical about a democracy getting through a week.
That's different enough. You can claim it for your own.
Right. Anyway, I think the key thing about it is, I mean, obviously you do have, and I think serious lawmakers all do want to create good policy, whether it's health or energy or anything else. But if you look at health policy, at least this is my own personal list of the desired things that you'd like to see come out of it. You'd like to have the capacity to better deal with illnesses among loved ones and family members. You'd like to build altruism and a better sense of community. You'd like to have better patient health professional relationships. It's a good idea. Obviously, you do want to improve healthcare privacy and security. It's a desired thing. Improve health outcomes and also health itself, care, through evidence-based medicine and actively engaging patients and caregivers so that, in fact, they are part of the team, if you will, in every sense of the word. I think you'd like to enhance personal choice on important health matters. Yes? Mm-hmm?
Priorities?
Pardon? No, they're not. They're not. They're just a basket. And, in fact, that's what we're talking about, is these are all goods. And to some extent, in terms of public policy, they're in competition. So it's not like there's an answer, but I will, you're anticipating a couple of my slides in a minute. And obviously you would like to have both healthy individuals as well as a healthy society. And ideally you'd like to have trust built in society. Pardon?
Some of these are pretty fundamentally different, some are related.
Yeah, exactly. In fact, actually earlier Eric and I were talking about something that both of us, at least in my roots, I'd worked at Wisconsin, in multi-attribute utility modeling, and I'm sort of puzzled somewhat that policymakers aren't using it more. I think it's really quite robust. And so, in fact, these are sort of just a basket at the moment, but they could be weighted and they could be ordered, obviously, to a specific challenge. But we've not really done that as a matter of public policy. And as far as I know, GAO doesn't do that either, or any group that's looking at these things. Now, the challenge, of course, and Cheryl Chandler's a colleague in the UK that in the past, healthcare didn't matter a whole lot. You could hurt somebody, but you wouldn't necessarily help them a lot. But the problem nowadays, it used to be simple, ineffective, and relatively safe. Now it's complex, effective, and potentially dangerous. And so your potential downside, as well as a much higher, rosier potential upside is there. But you increasingly need to know what you're doing. And if that was true in the past, this is a slide of Bill Stead from an Institute of Medicine talk a couple years ago. As we move from organs and systems and clinical cognitive capacity being what it is, where we made decisions by clinical phenotype, to moving increasingly to molecular medicine, our capacity to do any of these things without computer assistance is just quickly becoming, obviously, beyond the usual way of practice of sort of memory-based care. The thing is now to shift a little bit to privacy and health. Historically, for about 2,000 years plus, health has been considered both an intrinsic good as well as a instrumental good. In other words, there are times where it can be instrumentally useful to be healthy. You can climb a mountain if you're healthy, but it's also a good thing to just be healthy. Privacy has been considered historically by most philosophers as an instrumental good. And in the Hippocratic tradition, as well as the oath, it does speak to confidentiality of patient information among non-professionals, but actually the professional had an obligation to try to seek care for the patient and share information if he thought or she thought that the other person would actually, the other professional could help that patient and you couldn't. Similarly, part of this in the context of do no harm, you had an obligation to improve the art, if you will. So essentially, research was considered a piece of this, and oftentimes it was prognostically, so you'd know what case not to take if the patient wasn't going to get better. But clearly it was looking at knowledge and looking at research as an issue. So in the context of do no harm, it's not like you're not going to do something. You don't want to hurt the patient in the process of trying to help them. So it is an action issue, and research is key. And if you look at the early days of this country, you can't be from the University of Virginia without a Jefferson quote. So this is my obligatory Jefferson quote. You may not agree with this, but this is what he said. Without health, there can be no happiness, and attention to health then should come before all other objects. If you're from the Northeast, Waldo Emerson said the first wealth is health. Now I stand in front of you as a health professional. So there you are. Obviously, that's my way of getting out of bed in the morning.
As physicians, isn't it interesting that I think most people never think much about their health until they don't have it?
Well, it is true that, again, if you look at weights, what you put on these weights, if it's a nice sunny day and you're healthy, you put a different weight on some of the values, and these things shift. Again, how you would shift some of those would shift perhaps depending on your health status or other kinds of status. But at any rate, the point is, historically at least, health has been considered really pretty important. If you look at today, what's actually happening out in the real world, Utah has a law where patients can opt out from their children's immunization records being shared with other providers. If a kid comes into an emergency room, they can download and find out whether, so you don't over-immunize kids or also under-immunize kids. Parents can opt their children out of it. And this was probably about 4 years ago, last I checked, but less than 4% of parents do. So 96, 97%, something like that, actually stay in the system. The flip side of it, because one of the things you get into when you talk about these things are opt-in, opt-out, mandatory opt-in, out-out. There's a lot of ways you can go at this. In Massachusetts, they have a system where you have to opt in to having your data shared, not as children now, as adults. And I think John Lampke, the last time I talked to him, said that I think that it's something like over 96% do opt in to have their data shared. So the point is, if you look at places where people have to actually decide and do decide, somewhere around 90–95% of people are pretty interested in seeing.
That's de-identified data, though, right?
Well, it's secure. It's generally secure data. But the point is, I think the fact is they're trusting at the margin that the system will, in fact, will look after. Yeah.
Yes, just to be good to explain, I think, more exactly what that means in Massachusetts when they share. Does that mean they share all their data, including who they are, their identity, to anybody who's interested in looking?
No. This is among. If you go from one emergency room to a clinic or something, these are official providers.
On demand.
Yeah.
Right. Yeah. Patient demand.
Okay. And the data are obviously protected, secured. On the other hand, the clinician does get the data.
But if a set of Harvard-based clinicians wanted to do a study, could they work with the system?
That's part of what my talk is about. Okay. In other words, they don't have blanket uses to be able to use it. Now, if some of the argument that's gotten into the issue of privacy and patient data is the issue of trust, and that the feeling that if you're not very careful about privacy considerations, it's erosive to trust. Of course, that's difficult to quantitate. But one of the things that I think is interesting, David Mechanic, very distinguished professor of medical sociology at Rutgers, and co-researchers have actually studied this. And I think, again, what's sort of fascinating when they just go to patients and ask them, what are the factors that are important in trust in your care? The top one that comes out of that is, does the person, can I relate to this person? Does a clinician actually is somebody that actually I can even connect with? And oftentimes that takes a little time. But the point is this somebody that really listens and really hears what I'm trying to talk about and really meets me there? Next to that, and fairly close to that, is do they seem to know what they're talking about? Are they confident? Which obviously is quite important as well. And technical competence is a high priority. Oftentimes, though, that's not that well studied. It's kind of like, well, do they appear to be up to date on research or other kinds of things? It's not like this is a very sophisticated approach that a lot of patients take to this. The third thing that's important is, do they advocate for me? If I need to talk to an insurer to get some help or something, will they kind of go into my corner and fight for me for things they think are important for me? And if it even comes up at all, confidentiality is just generally assumed, and it rarely even came up as an explicit issue. So it's mentioned much less frequently than, again, oftentimes the conversations about this would tend to lead you to believe. It is interesting on the relative issue of trust in electronic health records that at least anecdotal evidence from a lot of these places that do have secure websites where patients are able to interact with their own data and even have dialogue with their clinicians, it does seem to actually be quite important relative to the sense of trust. So again, that's a space that I think isn't necessarily separated, if you will, in the electronic age. It looks like some of that, in fact, some of the communications technologies, it's not just information, it's really communication technology, can be really quite helpful to patients. So the point is that if you look now, though, shift from some of those things to say, well, where is it today? Where is privacy in this? In contemporary health policy, privacy is very important. And how important, I think, is really what we're talking about is how important should it be in the relative mix of a variety of social goods that you're trying to balance again. So that's really the question. Is it more important than quality, safety, cost, research, social trust, altruism? Where should it balance in this kind of scale?
Is there a sense for what are the, I mean, the people who talk about privacy, they're clearly concerned about certain things that can happen if privacy is not respected. And those are societal things, right? I mean, if you were in Europe in the 30s, you were concerned about your religious status being known because that determined whether you live or die. In healthcare, is there any consensus in the US on why is privacy important? What consequences of lack of privacy are important?
Well, I'll talk about that in some subsequent slides, and I'll get into it a little bit. But the problem, of course, using the word privacy is there's not even a common definition. I mean, confidentiality and security you can kind of think of in operational terms. Did somebody divulge something I didn't want them to? That's breaking a confidence. Is the system not secure? That's something I can sort of test. Privacy is a broader one. Yes, sir?
Maybe tangential. The economies recently wrote up the U.S. sex offender and sex offender register laws. How many new offenders would be created if the government trolls from all the existing medical records?
Yeah, I don't know the answer to that.
You have a guess?
No. At any rate, this is kind of interesting. I went to Bing just as an interesting kind of proxy of just throwing out words. And if you throw privacy on there, it was 1.2 billion. Community, 709 million. Health, 687 million. Health research, 343. You can read them. Trust, 157. You go down to freedom, okay? 9. And by the time you get to altruism, you know, it's just 1.2.
Can we assume Google is times 2 for all those?
Pardon?
Yeah. Assume Google is times 2 for
yeah, well, I'll leave that to you folks. Just as a footnote against this, sex outperforms privacy. But at any event, love, incidentally, doesn't. And death and taxes don't come close. So the point is, just as a weird sort of social proxy of at least what's circulating out there in terms of terms, I think it's sort of fascinating. The point is that definitions, to get at your question, definitions of privacy are not static. And in fact, as a matter of law, for many years, Brandeis had really pretty much defined privacy in American context from American law. And I'm not a lawyer, so some of these things I don't present to you as being something a legal scholar would present to you. But it was really defined as a right to be left alone, not be bothered. And in fact, the fact that you can call up a phone number and say, I don't want marketers calling me during dinner, is an example of the kind of the right to be left alone sort of thing while you're having dinner with your family. When current Supreme Court justice was being vetted by the Senate, he described privacy as actually saying really maybe not the best word. He really saw it as more trying to get the concept of freedom of conscience more than privacy, which frankly I think personally I tend to resonate with just at the personal level. But at any rate. On the other hand, I would say there are some people on the more rigorous end of the privacy that have been defined by others as privacy fundamentalists would say, well, I want the right to remain unknown, not to be left alone, but to actually remain unknown. And somewhere among all of these things are bubbling out there, and I have another slide in a minute to talk about it. But I do think that right now, I'd say that privacy in this country, we really do define it both as an instrumental and intrinsic good. I think we have crossed that boundary, but again, there's not a way to really know this. Now, there's been a fair amount of legislation over the years, and it's kind of fascinating that, in fact, in the 1970s, I think it was 76, but I didn't take the time to really look it up, the U.S. passed actually a law that did, if you were in the Department of Defense as a service member or in the VA, you actually did have your personal health information protected as a function of law. But because we don't have a national health care system, it didn't cover everybody. And it was fascinating because the rest of the world that did have then systems of care kind of passed a law like the U.S. law, but we never got around to it for doing everybody else. And by the time we started really trying to do that as a function of federal law in 67, 96, 97.
Was that actually known to be a template for the other countries?
Yeah, oh yeah, absolutely. We were clearly leading the world. And in some kind of ironic sort of way, the study I chaired on the computer-based patient record in '91, a lot of countries went off right then, and the VA went off and did it. As we know the story on that, and developed VISTA and a month-based thing that really then moved the VA from having some of the worst performance experience to some of the best of breed. So it's kind of fascinating that, again, so the price America has paid by not having, if you will, and it's obviously we're debating that at the national level right now, but I think we've clearly seen with a balkanized sort of approach to care that some of these things the U.S. actually has led on, but then necessarily hasn't across the country benefited totally from. Anyway, so HIPAA 1, I'll call HIPAA 1, was basically done as a privacy rule. It wasn't really mandated in detail. It was left for rulemaking, which is a very arcane kind of process, to decide what that would look like because the Congress couldn't come up with a clear decision. Actually, I had met with Senator Bennett on Arbor Day in 1995 and gave my little elevator speech, and he decided to in fact sponsor a bill, Senate 1330, which was actually a confidentiality security bill that got very close to passing the Senate and might have in fact actually bypassed that, but it failed just like a lot of other things. Most things don't make it through the arduous approach. So anyway, it went to rulemaking, and at that point I was chairing the NCVHS, the National Committee on Vital and Health Statistics, as Eric mentioned, during the for Secretary Shalala during the Clinton administration. When we went through all the hearings, we heard from 75, 76 people about what these rules should look like and advised the country on that. So I sort of have some scars from obviously that process, because this is not something that everybody's going to line up and agree on. That's just the way it is. By 2009, we passed what will essentially qualify as a HIPAA 2. And this time Congress did write some specific kinds of things, and then also did say there'd be rulemaking on a number of issues. And the fact of the matter is, I think that it's going to be a bit of a struggle to both see that care and research issues and medical research can in fact move forward, or all kinds of health services research, because of some of the ways this is framed. So part of the reason I'm talking about this today is this is dynamic, and it's not actually getting more balanced. If anything, we're running the risk, I think, of making it even more of a problem. Of course, the genetic privacy law did pass, and obviously one of the reasons I think that this issue is a hot issue in this country is where people can lose health insurance because of somebody finding out a prior condition or something. Our absence of having a nationally mandated universal access to care clearly torques the privacy debate, as well as an awfully lot of issues that are out there that relate to this. So it's not...
The congressional discussion in 2009 is explicitly talking about research interests and care. That's part of their actual discussion.
Actually, in this country, we sort of are dealing with privacy and research, care and research as sort of the same bag. And that's not the way Europe, the UK, Canada have approached it. They've actually approached it separately, as this is care policy and procedures and regs, and this is research. And I think, frankly, what's happened is it's hard to keep both of those balls in the air because the care alone is so complicated.
I'm curious if those terms are actually pulled out in the discussion, care and research.
There are elements, there are elements. And of course, obviously, if it's a matter of public health, as you know, there's there's a set of law that says, yes, you can get something for H1N1 or something like that. The public good from that context on a public health is not part of this, but clearly it's part of the total picture. Now, if you look at the market segmentation about attitudes of privacy, just to get to your point, question earlier comment, it actually hasn't changed a huge amount, at least from my ability to try to look at polls of this over the years. Since about Harris Equifax in '95, it may have shifted some, but the fact of the matter is about 20% of the people say, huh? I mean, there are different ways of saying huh, but it's just not something they think about or get exercised about. Somewhere around half are what you'd call privacy pragmatists, as their terminology, which is that, well, privacy as opposed to what? I mean, what am I trading off on this thing? If it's important enough, I might be willing to give quite a bit. Whereas on the other hand, if it's something trivial, hey, well, what are you talking about? Meanwhile, they defined it as privacy fundamentalists as being about 25%, but as I said, when you really get down to when people are faced with the choice on the pragmatic side, it's probably closer to, I don't know, 5, 10%, but that seems the way it seems to be playing out. At any rate, the point is that from those data, people had the highest confidence at that time, and I think this maybe has shifted a little bit, of data being used by researchers as in fact being the highest confidence. Next highest confidence were doctors, nurses, hospital administrators. So confidence in the use of it by insurers and employers, and in fact if you look at ERA 2, or HIPAA 2, on the ERA, increasingly how other business associates and such can use data seems to be tightening down. Yes, sir?
You're lumping doctors, nurses, and administrators in one pot. Are they about the same? Or
yeah, they were pretty close. No, they were really quite close. And I think the hospital administrators mostly where they were using it to manage the system, and they were just seen as actually part of, if you will, the legitimate kind of care process. But if you look at the full spectrum, yeah.
Go back to the slide. So this would argue that the general population has a pretty sophisticated understanding of the issues.
Yeah, I would say as general numbers go, but keep in mind these are sample data, and it shifts some. So it's not, again, like this is really, science in a really robust 0.0003 standard deviations kind of thing. But I mean, as such things go. Pardon?
Is it statistically significant?
Well, I'm not a social scientist in that kind. You need to have Eric answer that for me. But at any rate,
Numbers are pretty big to me.
I mean, the numbers, they have some confidence in it. Let's put it that way.
My concern would be, what's the definition of, when they hear the word privacy on average, what do different cohorts think that means? That's interesting. But
Yeah.
You said before that people forget about health as long as they're healthy, and I would suspect similar stuff happens, especially to medical privacy.
Well, I mean, there's just no question. I mean, just having practiced surgery for 25 years, a patient on one day as opposed to when both their disease can affect their way of thinking too. I mean, let's face it, it's not like we're separate from what we are and do. So there's a lot of reasons why some of these things are certainly mutable. At any rate, if you look at the full spectrum, Dan Macy's has this comment that in every global village you'll have a global village idiot. And I think part of the problem, unfortunately, with some of the early days of computer technology is that the Wild West idea of everything ought to be free and open and let anything go was, I think, part of why there was some concerns about, in fact, how responsible was this going to be as sort of an industry. As I said, I never saw a record I didn't enjoy, that kind of mindset. And at the total other end of this, well, then you get to privacy. What are you even talking about? Privacy versus what? I want to be left alone. I want to remain unknown. And then the purist was, I want everybody to be anonymous. I mean, there's actually some folks who would just as soon have essentially way off the scale. Anyway, so the question, I think, where are we today? And my assertion, and I'll present data that would suggest where we are in this current bake-off of social goods. I would say at the moment, federal privacy legislation and regulation is increasing healthcare costs. It is adding some greater privacy protection, but I'd say even the privacy people don't think it's adding enough, and most of the other folks see where it could be improved. And I think actually HIPAA 2 ERA will in fact tighten up some of those things. Clearly it irritates some patients and citizens involving seeking care, signing forms and so forth. It worsens the quality of care and safety, and I'll go through this, while contributing to a loss of medical privacy, given a key example of that. It does it, and I think the best case can be made, it impacts negatively on the volume of all types of biomedical and health research. And at the philosophical level, there's evidence, and certainly scholars, Honora O'Neill, probably the most distinguished, who's written about that it actually threatens community sharing and corrodes social trust and a sense of community. One survey at the time that HIPAA 1 was coming through, a study that the American Hospital Association, which you could say is hardly a neutral bystander, did a public survey on an instrument that showed that 85% of people, when this was coming in, the rulemaking, felt that consent requirements would adversely affect the care of the elderly, because patients might have a hard time understanding all of this and might get scared and so forth, and would therefore share data to frankly be in their interest. Time in doctors' offices would be spent with care and not paperwork instead of care. People felt like they'd be spending time on this. You could spend the money for patient care and get a better ROI. I did review a paper for a journal that didn't get accepted. The paper didn't get accepted, but there's the only thing I've seen that really tried to cost this out. But they'd costed out that it added, by their analysis at least, $1 per visit or $1 a day per hospitalization to deal with the HIPAA requirements, HIPAA 1. Says it'll be a hassle to sign the consent form before every visit to a doctor, hospital, or pharmacy, so forth. And then 60% didn't think it'd probably enhance their privacy. So there was a reasonable amount of skepticism actually going into this. I think the point is, though, does current privacy policy impact on privacy, safety, and quality? And the argument I would make is that the fact that we don't have a unique health identifier in this country, which almost every developed economy does have, is, I think, both a problem with quality as well as privacy. And the way that works, I was on President Bush's Interoperability Commission. The day we presented our report happened to be the day we were also having our national meeting at AMIA. And I think there were 5 members of the commission who were on that panel. And we went from the Capitol, where the report was released, to our meeting at the Hilton, and had a panel about what was in it. And a woman during the discussion period raised her hand and she says, "I've got a question I hope the commission addressed." She says, "My name is Mary Smith. Maybe you'll already guess where I'm coming from," she says. "But I'd love to have the country allow me to have a unique health identifier, because Mary Smith is not a really uncommon name in the U.S. And she says, I don't want other Mary Smiths getting my health information, and I'm absolutely sure I don't want my record to have the wrong Mary Smith's data, and then some doctor I'm coming to is thinking it's my data and do something to me. That is not sensible." Well, that's, although again, there's not a lot of science to prove that that happens. It's hardly what you'd call a strange kind of logic. And I think the chances that in fact that is real is true. Now, the fact is people have said, well, you can do all this authentication with algorithms, and you don't really need a unique number. But the fact of the matter is you do have a drop-off if, in fact, you don't have more identifiers that you can use in that algorithm. And Social Security number, for example, which when I was chairing NCVHS, supposedly in LA County was a toss of a coin because of so many people that had counterfeited Social Security numbers. But if you go to other places, I guess in Indiana, it gives you about a 15%, I think, better accuracy if you have it in the algorithm. Well, shouldn't people be able to choose to have a unique identifier that it would reduce, at least for Mary Smith? Now, if you're, I don't know, a name that's highly unusual, that's probably less of an issue, but it still is, I think, a safety issue as well as a quality issue. So that, I think, is actually is not trivial, and there are a number. AMIA has been on record for some years, hadn't pushed it, because it's, as you know, this was part of HIPAA, was a unique provider plan and personal health identifier. But pardon? Yeah, but it never went anywhere because there was such an uproar that Vice President Gore put a kibosh on it, and that's been since maintained. And so even the option to be able to do this is not something that actually, so we have a paternalistic view in there that opts you toward privacy, kind of whether in fact you really wanted to go that direction or not, which is part of my point.
Privacy uproar?
Pardon?
Under Gore, was it a privacy uproar?
Well, there were enough from the privacy. I'm a privacy advocate. I really feel like I am. In fact, I went, and as I say, I got 1330, even a bill sponsored at one point. So, but I think if you're really talking about the more committed, whatever, privacy community made such an uproar about it, and the New York Times was, it was a lot of fear got into the mix of the thing, and so they just said, we don't need that headache, and so they shut it down.
Yeah, I would think it would be more of an uproar about the implications for a national health system.
Well, they got a lot of things on their plate right now. And in fact, actually, that was during, the Clinton administration, and I just think they didn't want to mess with it. So anyway, so the question then, moving to research, which really has the most information. Yeah.
Go back to the Mary Smith problem.
Yeah.
What happens if you say Mary Smith, January 1st, 1985? Right? The name and birthday.
Well, again, if you look across the U.S., Probably not just one Mary Smith that was born that day. Or was the birthday really recorded right? And do you have different ones of these? So, I mean, the point is that, you know, the algorithms, you probably still will absolutely want to use an algorithm.
Yeah. Security number together with the name.
Well, as I said, you have these things all give you an added additional accuracy. But the fact is, if you can have another unique number, it does at the margin give you even greater accuracy. And right, the point I'm trying to make is that right now our federal policy is not allowing us to even call a number and say, why don't you use my passport number or my state driver's license number as a unique health identifier? It's fine for me. Okay? That's what I'm saying. That's not an option right now. And it has both privacy implications, you know, as well as health and safety implications. Okay, research. This is probably where, and if being at Microsoft Research, this is probably where I think the best evidence exists that it's a problem. There have been, in the first instances, the Association of American Medical Colleges, the American Hospital Association, American College of Cardiology, American Society of Clinical Oncology, the NCAB, ARC, Academy Health. There have been a number of survey studies that have suggested and shown that the HIPAA does in fact impact negatively on biomedical research and health research across the board, all kinds of whatever research you're engaged in, and whatever kind of research that you're doing that relates to person-specific information. In 2007-9, the Association of Academic Health Centers, but probably most distinguished and influential report just came out from the Institute of Medicine. But at least the point is none of these studies have given conflicting evidence that, oh no, it's not so bad. Everybody is pretty much in agreement that this is having an impact. And in fact, there are some people who feel like it's much easier nowadays to do research in other countries because of the costs generally are not that cheap to do certain kinds of studies, and by the time you have to do all this data management as well, it just becomes at the margin something that's problematic. Now the question is, will HIPAA 2 make this even worse? And I think there are a couple areas that are concerning some of us. One, it's advocating use of minimum data sets and in fact changing the rules on when data is anonymized and arguing to try to move to minimum data sets. And it also gives business associates, it brings more business associates into it, and there are penalties that if the data are misused, the business associate may pay quite a penalty. And in the UK, when they were going through this, when I was over there at Cambridge, and they sorted it out, but at the time, they were, again, putting more institutions to greater culpability. And the institutions were saying, well, why do I want to go through a risk of having more problems come down on my head if I don't give data for research? I save myself a potential exposure.
How do they define minimum?
Well, that's part of the rulemaking process. So that's, you know, you can go to the web and check some of that out. But the fact of the matter is,
for research task might be a little bit challenging, especially when you can discover not just known variables but hidden variables at work with data sets. To say, just give me these three variables.
Well, and this is why I think that again, it depends on the kind of research you're doing. But again, at the margin, I think it would make things more problematic. Now, there's a set of timelines on this, and I'm not going, in the interest of our time, I'd like to have some also time for open discussion. But there's a set of things that relate to all of this, and they're arcane enough, but important enough, that I think the research community should really show at the margin more interest in tracking some of these things, and at least today I'm aware that they're necessarily doing. That's personal, and you know, I think there is interest. These things are being traced. Well, what did the IOM say? In Beyond the Privacy Rule, they basically were saying two things. Now, privacy isn't as protected as it needs to be with the current way we're doing it, but we also are impacting negatively on research. We could probably build a better mousetrap. And the fact was that it said HIPAA doesn't adequately protect privacy security as well consistently as it might. I think ERA will actually help some of that by broadening some of the coverage. But it doesn't facilitate legitimate research, especially database and repository research. And it's fascinating that if you look at the ERA, it talked about comparative effectiveness as a research and using data repositories to look at comparative effectiveness. So it's kind of fascinating. There's a discordant tension in there, which was part of the reason why I thought it might be kind of an interesting talk to try to summarize where maybe we are on this, is that even Congress sort of seems to, in a sense, to recognize that they want two things, but they aren't necessarily managing to them simultaneously. Yes?
Evidence was offered to illustrate that security and privacy is not being preserved, despite HIPAA 1. I mean, both.
Well, I think most, the question was, what's the evidence that we got that big a problem, if you will? I think a lot of it is you know, the occasional highly publicized situation where a Veterans Administration computer turns up in somebody's car or is stolen and something, and or thousands of Social Security. So it's in fact, it's really fascinating. If you look at, keep in mind that with Medicare, since 1965, all health data on everybody over 65 in order to get payment has been sent to the government. And how many breaches, I mean, you know, have you heard about? So, you know, clearly the performance, at some level, there's a disconnect between, I think, in some instances, the popular sense of how serious this is. I think a lot of it, though, is not that, you know, if you really are a sophisticated hacker, it's really tough to, you know, protect all this. You guys are experts at that. So it's not as though, in fact, you can run, but it is kind of hard to hide. So the other issue, though, is where is it? So it's both a science issue, but it's also a perception issue, too. And obviously, you live off the perception issue. Yeah.
After some bad case in Britain,
yeah,
we got to the stage where the word unencrypted appears in the general journalistic literature.
Well, I mean, I think the fact is there are problems, and I don't think that we're, you know, realistic to be standing here saying that there won't be some problems, can't be problems. It is an issue. These are competing goods. They are goods, and they're in competition. I think that's the issue. You're not going to come up with obviously an ideal situation.
Financial industry, right?
Pardon?
The financial industry. They deal with data, and you know they have ways to value data, and they deal with risk, and they manage it, right? So I mean, here's an example. We're talking about very high quality, very high value information, and you learn to deal with it.
Well, yeah, the point was made that, you know, we have an international financing system. I can go use an ATM machine in Italy or wherever, and traveling somehow seems to basically fly. Yes.
I would add, every single privacy document I get from a financial institution says we will not disclose except as required or permitted by law.
Yeah, and in fact,
telling is they can do what they damn please.
Well, I mean, this is part of the other issue, because for payment and quality and all these sorts of things, there are a large number of players, again, in our kind of system, that will see your information. And believe me, fraud and abuse is not a trivial consideration. I mean, the president the other night was saying, well, we could probably pay for most of our healthcare problems if we just clean this up. So, and that's not totally off the mark. Fraud and abuse in this space is really huge. Anyway, the IOM said that really the HHS should really develop a new approach. And it really should favor de-identified data sets. And it's interesting that, as I said, limited data sets is included in ARR. It's not clear how that'll come out. But at the end of the thing, they're saying that HIPAA should just exempt all research from HIPAA rule. It's enough of a social good that we don't want to pay that much of a social price. We need to protect it better where we can and should, but we ought to manage to this as research as something that is obviously important. I think taking the sense that, gee, at the start of the genomic era and such, there might be some things that could really improve patient health. So if it didn't matter, I guess you wouldn't see, if research didn't matter, so what? But increasingly, I think it does. And as I made this comment earlier, the fact is the U.S. has taken a different approach to this than Europe and Canada. Yes, sir?
You said emphasize de-identified data. When you start talking about genomic information, it's really hard to get de-identified data at that point in time.
Yeah, you're not just whistling. In fact, Russ Altman, who's a professor of translational bioinformatics and computer science and health and everything else at Stanford, gives an annual Science of the Year presentation at our translational bioinformatics meeting in March 15. He talked about how tough it is to actually, if you will, anonymize your genomic data. You have to, there's a lot of fingerprints on a lot of SNPs, and if you really want to deal with that's not a trivial task, as you pointed out. And I think there was a general a surprise from some of this more recent research that it's a little tougher to do than in fact people were even thinking 2 years ago.
I mean, there's still so much there to do it. If that's the target, then you're going to still be in conflict where you can't really...
Well, and that will get to part of my, at least, reason why I think we need to think about, not to downside the privacy, but from the IOM perspective, find more creative ways to also let people, in fact, express themselves as free citizens in a free nation to say how they choose to use their data, and given some of the options to do that.
You can't do that now? Even
no,
I said that?
I am not, as a citizen today, the government does not help me have a unique personal health identifier. Okay? Meanwhile, but they do.
Can I do that on the site? So if you look at the personal genomic space, right? So 23andMe or whomever, so they're getting genomic information. You can fill out their surveys, you can get all this other stuff in a
Yeah, but I'm talking as a matter of government policy.
Got it.
Okay? I mean, it's a free country. You look like people like me or Faster Cures or some of these where people are giving all their data. And so it's no question. Okay, so the point is, the other thing is true about this. If too many people opt out, the free rider problem comes up. Nobody leaves the station. So it's not like it's simply a trivial matter that, well, just let people totally kind of choose. Now, on the other hand, I'd say the evidence to date would suggest that you would have cohort sizes pretty darn large. If you're up around 80, 95%, that's pretty good. And so it looks like, frankly, that you'd come out okay, but we don't give people, as a government policy, that opportunity. Yeah.
I mean, the cohort size of 85% may be enough to skew the data badly. The recent report on HRT and breast cancer really depended on the fact that one set of cohort was voluntary, the other was not, and the numbers flipped around.
No, it's not a trivial issue. You're absolutely right. In fact, Minnesota during the 80s, early 90s, I guess, passed a law that you had to have people's permission to use their data for research. Mayo Clinic had been in operation 150 years. They'd never had a complaint from Olmsted County, anybody ever in their history, and they had this law. Well, Mayo Clinic is not a trivial institution in Minnesota, and neither is the University of Minnesota. And so the legislature came back, rethought that, and said, well, you got to make a reasonable college try to reach them, to get an answer. But if you can't get them, you can use their data. And it turns out they changed the law, and again, it's sort of things that moved along. But the interesting thing was, during that period, it was disproportionately young women who were opting out. So if you're talking about breast cancer in a young cohort kind of breast cancer, you sort of make the decision for everybody. So it's not a totally free kind of thing, and I think your point is a good one. At any rate, I think it's also true that many research projects absolutely need to authenticate who they're dealing with. They're not interested in Don Demmer, but they're interested in knowing that it is this person. And so sometimes you do need to definitely be able to know that. And of course, I think, Eric, some of your research has tried to deal with that, but some of the things you can answer and get some pretty good data on, but other kinds of things would probably be more robust if you actually were able to really know who you're dealing with. Anyway, Madison, I quoted Jefferson a little bit, another local to UVA in Virginia, James Madison. He was part of the original founders. His quote was, "A popular government without popular information or the means of requiring is a prologue to a farce or tragedy. Knowledge will forever govern ignorance, and the people who mean to be their own governors must arm themselves with the power which knowledge gives." I mean, again, we've had a tradition that sort of says, and if you look at our census, it goes back to the founding of the country, we've typically really have, I think, sort of argued that data and accurate data, the best data we can, is really a social good and something we should do. I'm running a little short of time. I think the point is, I think some of us were not as strong on the switch as we might have been when we were going through this. We were focusing on it more from the privacy side and security confidentiality side. and didn't really kind of have a more robust thing. I'm partly responsible. I started the working group on the National Health Information Infrastructure and didn't have, in fact, in that model, either education or research. And so it's a mea culpa to some extent. But the fact is we need a more robust model, I think, to be thinking about this. More recently, I think the Office of the National Coordinator, struggling in a lot of important things, was continuing to do that as well. And of course, I think there have been enough activity from the privacy, stronger advocacy side and some of the mental health community that have offset the fact that the researchers have not really come out of the woodwork on this. They got a lot of things they're thinking about and worrying about, and they really haven't particularly stood up sufficiently to balance it, outbalance it. And as Madison also noted, nothing is so as contagious as opinion, especially on questions which, being susceptible to very different glosses, beget in the mind a distrust of itself. And I think we've seen some of that. There have been concerns where a very egregious lapse in a specific place has been generalized and seemed like, well, must mean it's all going haywire. Yeah, exactly. And so again, that's hardly new to our time. So anyway, the thing that I'm really positing here is I think we really do need both policies and standards that do try to, in a free society, allow us to better manage to these things without saying that privacy isn't really important. So the question is, how do we enable this? And I think in a few minutes, I think we need a new model on the standard side, and then I think we also need to have a few new policies that in some instances could be federal, in some instances could be state. This will be available, I think, in fact, there's a number of people, I guess, that are watching this elsewhere now, and it will be available to go down through this. But the point is, today we don't have a single consent process to allow citizens to share their personal data. If they say, look, I'm interested in the public good, you know, at age 70, what do I got to hide or worry about? Particularly, I'm willing to take the gamble. You can use my data and put my name on it, so that's just fine with me. And I'm willing to take whatever downside is that might come from that. If you don't want to do it, don't have to do it, but allowed to do it. And rather than having to do it institution by institution, by program, by program, by program, actually have ways to facilitate access as well as, obviously, for those who don't want to do that, not do it. So I think the point is that in a lot of these areas, it's not like what we've done is wrong. I just think it's not quite been balanced. And so for now, though, this is going nowhere. This unique identifier thing right now is going absolutely nowhere in the water at the federal level. And I think the point is that my argument would be that why couldn't you allow the citizen to choose an alphanumeric number and allow them have a site where that's done. And also, as you'll see, relate to this. I read this book, Nudge. I don't know if you read that. But it's an interesting, I think, point that if you're in the cognitive psychology area, if you could just nudge people a little ways, it doesn't really cheat a lot, and it frankly makes society better, makes everybody in a better situation. They use the term libertarian paternalism. As I already said, we have paternalistic policy today, but we don't have offsetting paternalistic policy at the same time. So anyway, the reality today is that we really don't have a proposal for action to allow, informed consent across a broader kinds of scale for legitimate IRB research. You could do it based on IRB-approved research. And I think we do know that, obviously, talk about the genome and so forth. I mean, this is a time when, obviously, these are not trivial kinds of questions for human health and disease. So I think we have a question here that's real. And also, it's not like the citizens and the people, we're putting a lot of billions of dollars into research as a nation and the states and so forth. So the point is, there's a lot of sense with, for example, 38 billion going to our own national health information IT infrastructure for electronic records and such. So we clearly want this, but we don't necessarily have it balanced as we might. So what I'm personally advocating, and I've talked to a few states, I'd like to see, I have on my driver's license in Virginia a little heart. I can say I'm willing to see my organs used for transplant. At my age, it's probably my corneas. That's about all I'd be interested in. But the point is that I'd like to see a few other icons there, that if there's not a slash through it, you can use my driver's license number as a unique health identifier. And if there's not a slash through it, you can pass my data around among health professionals, have a website so docs and institutions could check and see where I was on that. Have another one, a little microscope, saying you can use my data for IRB research. And I'd like to have in some states an option which is say, if I call or send an email to you, if there's a protocol that comes up that might apply to me or my family, you'll push something to me so I can maybe sign up for it, participate. And then the last one would be a little DNA spiral that would say you can use my genetic information for that. Now that would totally change the picture of things. I think it's totally consistent with a free society. Probably the state level is the best way to do it instead of federal, frankly, because currently our main ID is our state driver's license, and the organ donation thing is something that the public's certainly familiar with. But I'd prefer to see it actually as a mandated thing. You had to choose one or the other at the time you got your license. But in addition, what I'd like to do is have some pilots.
The doctor's bag might get confused with do not resuscitate.
Well, whatever. I'm not here to advertise the icons. I think that's a good point we need to figure out. With certainly after the death panel and all that business, we probably ought to talk through those things. But some kind of simple thing. What I'm saying, it would have some credence. I mean, who's using a microscope particularly today either? But you need some icon that might work. And that's part of why pilots would be smart to do. And now obviously have user groups that would look at some of this. So you could look at opt-in, opt-out, mandated choice, and so forth. So anyway, I'm talking about this. I'm on Bob Kahn's National Corporation Research Initiatives on his board now, and I think we've been talking about some ways to deal with keeping those data secure in that kind of an approach. And obviously, it'd be nice if Washington State would want to be a partner in that. Clearly, they do a lot of research. Anyway, I probably have had too many slides in this deck, but I really do appreciate the opportunity to come, and I'll be interested both now as well as later on feedback you might have, literally in any direction. I've been at it long enough that there's no such thing as unimportant feedback, and that would be great. So thanks again for the invitation. I don't know if you're interested, but if you are interested in an annual symposium, it's middle of November, not too far from here. So anyway, thanks very much. Thanks again.
When a while back my credit card was compromised, I got a new number and a new card in the mail 2 days later. Try that with Social Security numbers. And think what happens if somebody from Virginia moves to Maryland, God forbid. And until they can handle Social Security numbers as well as a cheaper credit card company, I have my doubts.
Well, maybe they'd subcontract to Microsoft to do it.
Well, so one of the things that would be interesting is I thought about medical records as, who owns medical records? Today, I don't know, as I look at my credit report and all this other stuff, the information that's stored about me is not owned by me. And I have no control over whether they use it for, the banks use it for research, they have all the credit card records, and they use it to profile me and do lots of stuff. Has there been any thought that says, we should really make medical records owned by the individual? And if you have a test, you have whatever, you've got them available to you. And then you could go and participate in studies. And you could then give your information. Now, you do that individually one at a time, where you could put it into a repository that then made it available or things like this.
Well, in fact, the Congress did recently pass something along that line, and I think it's a terrible law, personally. I'll tell you why. Personally, just from my perspective. It says that basically, if you don't want any data to go into your record, and you pay for it, rather than the insurer getting the information, then it doesn't need to be in your record. And what I don't like about that is that, oh, okay, so if I'm poor and I don't have the money to be able to do that, I have absolutely no choice. I mean, I just think it's not good law. So from my perspective, there...
Find the law differently than I would have done that, where you're saying I have to pay
Well, that's what the Congress has done on that. I mean, you can opt out, but you have to pay the freight if you're going to opt out. But the point I'm making is that it's basically regressive. It's very regressive.
Yes.
And so I'm not saying you're advocating that, but I'm just saying that's the closest thing we've tried today to have a way of letting people protect their information. Now, the other concern, of course, on that too is, as a clinician, if I then subsequently am taking care of a patient who's decided to not have this information in their record, and I prescribe a drug that absolutely would be counterindicated based on if I knew that information, is the government going to protect me from, abusing, if you will, making bad malpractice because obviously the person's done it. So I think this is another dimension of social good that's really, really critical. And I think there's a lot. We have a chat room, American College of Medical Informatics. We had a lot of buzz on this issue, and our feeling, frankly, at least it's not a policy, but of the sort of the minds, is that we really need to make sure that if people take that route, they realize exactly what they're exposing them to. It's much more serious than they might on the surface think that it is, that they're just sort of interested in that they can have a cake and eat it too necessarily. Because I don't think, in fact, Congress is likely to give you that kind of malpractice coverage, if you will. So there's a lot. So then the question is, well, if somebody chooses to act that way, would you decide to just say, look, you need to find another care provider? I'm just not willing to take care of you under those circumstances. It's too problematic for me as a caregiver.
I think the law, as you described it, is a totally worthless thing. Right. And so that's not what I was saying, where you can pick and choose what goes into your record and what.
Well, but that's currently the
I understand. I appreciate that. But
no, I'm sorry.
I'm proposing an alternative then.
Right.
That really is, fine, you guys, the insurance company has the record as well, but no matter what goes into it, I get a copy of it.
Historically, look at the data ownership. Historically, the institution and the clinician have owned the record. Mm-hmm. And in fact, actually, when a physician changes practice, he sells oftentimes his records to the next provider that's coming in. So it's not a clean, this is mine, and if you will, for all time and so forth. It's actually, in fact, we just did a couple of studies, a couple of policy projects at talking about secondary health data. When we did the IOM study in '91, we sort of said if it's involved in care itself, it was considered primary health data, and all other uses were considered secondary. We recently said, look, we should avoid this issue of ownership because, frankly, leads to just a lot of discussion and not good public policy. Instead, what we should talk about is what are good stewardship principles for anybody that's going to have access to person-specific health information, and what are really, in fact, the way you treat these data. And in fact, with a fair amount of both kind of moral guidance as well as obviously some legal constraints as well. Because so in other words, secondary data, as we ultimately defined it, was only those data which are being sold to somebody without any conceivable possible benefit back to me. I'm not being paid for it. There's not likely to be any good coming back to me from that. We now say that you probably ought to consider secondary data. But otherwise, to run a healthcare system and look at quality and in fact, actually, HIPAA 1 basically sort of said, well, business operations, quality, payment, and so forth is a part of care. That's basically how they defined it. So they basically even sort of defined it that way. And then they're trying to kind of tighten up some of that. And then with the personal health records, how do you look at other kinds of associates that might see some of those data and put some of those protections? Whether in fact they say, look, we don't need it, we're good guys and gals, or not. Yes, sir. I'll be happy to stick around too if we want to break this up.
Extrapolating from some British data, there's a wild extrapolation. A fake phone call, some charlatan claiming to be a doctor and saying he has a Mr. Detmer in front of him, unconscious and breathing funny, should happen roughly twice a minute in the US. Although that's because it's a big country. The numbers are from Ross Anderson on a little NHS region.
Maybe you guys can take that offline, that discussion. Okay. Say, did you have anything?
Yeah, so my question is that it seems like there are two issues that are almost orthogonal, but in your presentation they were very tightly interleaved. Identity and privacy. I mean, at some level they're orthogonal, right? You don't need identity to have privacy. One helps the other. So why is it so critical to sort of address them in that put?
I think that's just the way the policy dialogue is kind of worked out. I think you're right. I mean, how some of these things necessarily get into the same bed doesn't necessarily have an intrinsic. If I'm tracking on your question, I don't know. But if it gets into the policy debate, then it's in the debate, and you get to deal with it whether it kind of makes sense or not.
Do you have evidence around different models that other countries?
Yeah. Oh, yeah, sure. But obviously, I didn't have time to get in. I mean, when I was in the UK, I was actually party to some of the discussions. In fact, I was a member of the Nuffle Trust, and we had a policy meeting one night, and Lord Hunt, who was the Undersecretary for Health at that time, as we were discussing this, he says, well, now that you mention it, you know, this is a serious problem. Right now, I got a committee that's looking at this. And so normally we would break for a nice dinner, and instead of breaking for dinner and letting it go, we went back into session and tried to give him some advice. You know, I'll leave it at that. But the point I'm making is, yes, this has been certainly, and I think some countries have done a much better job. And some of it's actually because of the importance that the biomedical research industry is to the nation's economy. It's not like there aren't economic dimensions of what we're talking about, too. And in fact, I think that also is an issue here that I didn't even obviously talk about at all.
So that's a very interesting point. So you can foresee, say, some smaller countries getting a competitive advantage from having the right kind of policy framework in place, right? If they had the industrial backing and a public consensus.
Well, clearly you look at stem cell research. I mean, obviously that's the most recent example of I mean, this is a global market. You look at medical tourism to Bangkok, and again, we priced an awful lot of people onto a spot market internationally, and it's not a trivial issue. They're all board certified in American medical specialties, so it's not like they're not well trained. The hospitals are very good. So that, yeah, there's no question. We are in fact, a global kind of market. There's also opportunity, unfortunately, as well, though, for abuses in some countries and exploiting people. So from my perspective, again, I think it's part of why I'd like to see us deal with this better, is that I think the fact is the world does pay some attention to what we do at the margin. And if we had better policy, I think everybody could benefit from that as well. So it's a little bit of selfishness in that context, too. Anyway, thank you very much again for the invitation.